Here today with Lauren, one of our nurse practitioners here at Atlas, and we were going to have a discussion today about diabetes, about some of its core causes and how to diagnose it.
I'm excited to talk about some of those things today.
Lauren, what do you tell some of your family members or some of your friends as they are kind of concerned about whether or not they might have diabetes? What are some of the things that you tell them to be on the lookout for?
So some of the common things that patients may complain of is increased thirst, unexplained weight loss, frequent urination. So sometimes that's kind of a sign that we'll say, hey, let's check an A1C or fasting blood sugar and just see kind of where you're at.
You know, and a lot of times with that increased thirst, what people don't realize is when the blood sugar gets really high, that it almost tricks your body into thinking that you're dehydrated. And so you want to drink more and more water. And then what also happens is when people are now losing all this sugar through their urine, they may also start like really losing weight. And so we always tell people that if you're having any of those things, certainly go to the physician, go to your doctor and get checked out. But you know, a lot of times when we are trying to diagnose diabetes, most people don't have those symptoms at all. In fact, I would say most people, when they get diagnosed, don't even know that they have it. And so a lot of times, you know, I would say probably the last 5 or 6 people I've diagnosed have just been here in the office with yearly labs and things along those lines. What are the things that you're looking for in order to help make that diagnosis of diabetes, or even to look at people in this pre-diabetic state before they would get to diabetes?
So usually with yearly labs, we'll do a CMP, which will show glucose level. And if it's elevated, usually I'll bring patient back and do an A1C. So pre-diabetes begins at an A1C at 5.7, and then to get that diabetes diagnosis is 6.5. So once they kind of meet that.
Yeah, and for those of you who don't know, so a CMP is just some blood work, and usually with yearly labs, we're going to take that when people are fasting, so when they haven't had anything to eat for 8 hours or so. And then an A1C is usually a really easy blood test that we can do in the office, where it's just a quick finger stick, and in 3 to 4 minutes, it'll tell us kind of what the average blood sugar has been for the last 90 days or so. I remember having a friend in high school who had diabetes, and he had to take insulin, and so just growing up, I always assumed that diabetes was just an insulin problem. But there's actually like 8 different defects. But some of those defects are really more important than others. What do you think are some of the more important defects that we end up having to treat?
Insulin resistance, as well as just the decreased insulin secretion. So like the pancreas is not excreting enough, so therefore you've got that
almost like an insulin deficiency,
right,
if you will.
right.
Yeah. When you see some of especially for those young folks, when their pancreas is being destroyed, it's like all of a sudden they're not making any insulin, and so they have to take insulin. But outside of that insulin deficiency, what is insulin resistance?
So insulin resistance is when the body becomes resistant to insulin, so therefore the glucose cannot be used or the glucose is not used for energy.
And a lot of times what I've noticed as well is as people's adipose tissue or fat tissue, you know, it's almost like a snowball. The more insulin there is, it seems like the more deposition that we get right here, especially as guys, as we get a little bit older, we get that spare tire. And the more adipose tissue, it's like the more resistance, and the more resistance, the more adipose tissue, and it's almost like this snowball effect, where a lot of folks are trying to lose weight. They're trying to do that and do what's right for diabetes, but that insulin resistance really makes it difficult to pull some of that adipose tissue off. And surely fat tissue is a lot more resistant than muscle tissue, for sure. And a lot of the medicines that we use these days, I think, probably contribute to that. And one of the other things that's always interesting to me, we see this idea of that adipose tissue and the idea of lipolysis, which really just means a breakdown of fat cells. Fat cells are just a storage mechanism for energy, but part of the way they store that, they have these sort of what we call small chain fatty acids, and that's just kind of a big term for, you'll hear people with triglycerides and people who go on ketosis diets who are going after these as a source of energy as opposed to glucose. But the problem is when you're having that much turnover at the adipose tissue, is it's really inflammatory. And I think that's the other part of diabetes that people don't realize, is it's not just blood sugar that's an issue, but there are all these other things that come into play. Like the liver at night, was one of the things. Tell us a little bit about like why you use metformin, and sort of a little about the benefits of metformin with some of the glucose at night.
A lot of people don't realize that whenever you're fasting, the liver is producing more and more glucose. So say they had a pretty healthy meal the night before, they go to sleep, they wake up, and their blood sugar is spiked. So that's why we use a medication called metformin that kind of helps with that issue.
I have that issue, I would say, very commonly, right? I think it's one of the most frustrating things as a diabetic is when they come in and they say, I tried to eat really good last night, and then this morning my blood sugar is really high. But the flip side is when I had a really bad meal the night before, my blood sugar was better the next morning. And it's really hard to understand sometimes as to exactly why that is, because we're so focused that diabetes is only a condition of blood sugar and insulin. And we kind of forget that it's not just about what's going in, but it's also part about what our body's producing and how our body handles it, which is really important when you're trying to manage it long term. And in particular, right, it sort of informs us a little bit as well as to what some of the chronic problems are with diabetes, because it's not just the fact that the blood sugar's high, right? It's also the fact that you've had all these other things that have occurred, as well as just metabolically, the things like the inflammation in the small blood vessels. We do a lot of screening for that here. Could you tell us a little bit about kind of what do you think is a harder thing to get patients to screen for? Problems in the eyes, or problems in the kidneys, or problems with other small blood vessels like in the toes and the fingers?
So some of the things that we do screen for with our yearlies with patients that have diabetes or we think could possibly develop into diabetes is we do a fundoscopic exam, which sometimes patients are like, well, I just had this done, or sometimes they can be a little hesitant to want to do this. Well,
so with the fundoscopic exam, before you move on from that, what that entails for us here is that we're able to actually take a picture of the back of somebody's eye called the retina and look for any signs of early damage with diabetes. With that, of course, we also do microalbumins.
Yes, we do those. We take a urine sample and check that for protein.
Tell everybody, why is it bad for us to see protein in the urine?
So that can indicate that there are some kidney damage issues.
And that's really important, because what it ends up showing us is that with these really small blood vessels, we know that if there's problems in the kidneys or in the eye, that it's also in other places like the brain or the heart. And so if we can do a good job of screening out and finding problems early, we can see in the back of the eye, right? We have kind of a picture or a window into the kidneys by looking for the protein there, that we know if we're seeing complications there, that complications are going to arise in these other places. And in particular, we think brain for stroke, we think heart attacks, and then we also, at a very late stage, we start worrying about people's fingers and toes, because that's the other place that we see these really small blood vessels at. Certainly we'll have a few more videos kind of coming out about medication and how to manage diabetes and avoid some of these complications, but I appreciate you coming up and us having a discussion.